thank you, everybody. This is a new episode of Fresh Air, and thank you for all our colleagues for attending. Thank you to Matt for organizing everything, being the technical guru, the brains behind this operation from Ontario, Canada. I somehow always get that wrong, but this time I'm getting it right. London, Ontario, Western
You got it
University
right.
is
Yeah.
where Matt
Yeah. Thanks, Sanjay.
practices. Then Dr. Sharda Nagoti is from Hyderabad, India. She is a pure pulmonary pathologist now, and maybe it could be that she's the only pure pulmonary pathologist in India. Very, very happy to have her. Dr. Irene Sansano is from Barcelona and is also a very dedicated pulmonary pathologist and a SRIF enthusiast. So very happy to have her on my side while I discuss this new concept. Dr. Raghavendra Pillappa is a Mayo-trained pulmonary pathologist and practices in Virginia Commonwealth in Virginia. So welcome to everybody. So what we're going to try and do today is discuss this new paper on smoking-related interstitial fibrosis, or SRIF. So I'm going to try and share screen first. This is the paper we're going to talk about. This is entitled Smoking-Related Interstitial Fibrosis, or SRIF, as I'll be referring to it from now on, SRIF in patients presenting with diffuse parenchymal lung disease. And this is a paper that just came out in the American Journal of Clinical Pathology and was authored by our Cleveland Clinic clinical team. So I think it's a really big deal. For the first time, we have some evidence of SRIF in patients presenting with clinical evidence of interstitial lung disease. And that's why this is kind of an important paper to discuss. And what I'm trying to do is show you in detail the findings of one of the cases in this paper in more detail than you can show in a publication. You know, in a publication, you can only take one image or two or three images. Typically, they're from different patients. It's very difficult to get a sense of the overall picture in one case, especially in interstitial lung disease where there are biopsies from various sites. So the case we're going to talk about, there were actually 6 cases in this study. All of them had clinical features of interstitial lung disease. All of them were smokers, and all but one were in their 40s. So these patients were in their 40s. And the one we're going to talk about is actually case 1. So let me just scroll down here. And if you look at this table, this is table 2 in the study. We are going to talk about case 1. So this was actually, if I'm not mistaken, the only male patient in this series. All the others were women. And you can see here from the pulmonary function tests that the most severely affected thing here is the DLCO, or the diffusing capacity for carbon monoxide, which was 39% of predicted. That's very severely reduced. Actually, interestingly about this patient, also had very severe clubbing, which is not a usual feature that you think about in smoking-related ILDs. But I think that's one reason that this patient actually went to biopsy, and many other things were considered here clinically. Could this be NSIP, UIP, CPFE? I think the clubbing was one of the features that made them consider a more severe interstitial lung disease. But I'll come back to the clinical later. Just wanted to show you. So case 1, the most severe thing was the DLCO reduction. There was actually no obstruction or restriction on pulmonary function tests. So any questions about that, guys, about the pulmonary functions in this case? So case 1. All right. The other thing I wanted to show is, so this is our sort of main table in this case. And really the main features of this case were progressive dyspnea on exertion. This patient also had cough for 2 years and clubbing, as I mentioned, and there was a wide differential diagnosis. And you might wonder why sarcoidosis was in the differential. So the interesting thing in the story is the patient was actually being treated for COPD exacerbations at another hospital. And during one of those exacerbations, it was hospitalized, and then on a chest CT during hospitalization, they noted mediastinal and hilar adenopathy. So because of that, the question of sarcoidosis came up. It was not looking like sarcoidosis on the lung images. It was the hilar and mediastinal findings that brought up the sarcoidosis issue. And then when the patient came here to our institution, smoking-related ILD was brought up on radiology, but actually on radiology, a lot of other things were also mentioned, although considered less likely. So they were Langerhans cell histiocytosis, cryptogenic organizing pneumonia, eosinophilic pneumonia, LIP. So there was a wide differential, as you often happens, on radiology. They say, here's what we think it might be, and there are many other things that it less likely, but also could be. The radiologist, interestingly, also noted trivial centrilobular and paraseptal emphysema, mostly in the upper lobes, and the findings were really bilateral symmetric ground glass opacity. So let me just show you before we go to that, the radiologic findings in this case, which are also shown in the paper. So this is case 1. Here's the case. So on the left-hand side, this is radiology from the upper lobe. You can see ground glass opacities predominantly in the periphery. Do you guys see it? Is it visible on the thing? Predominantly peripheral ground glass opacities. Here's the middle lobe. Again, you can see very faint haziness, predominantly in the periphery. Actually, there is some subpleural sparing, which is interesting when we think about, NSIP versus UIP, and this often comes up, subpleural sparing. And again, in the lower lobe, there is ground glass opacity. There's a single cyst. I hope you guys can see. There's only one cyst in the lower lobe. So that's why they thought LCH was not likely. There's no nodules. It's not upper lobe predominant. There are no multiple nodules. But definitely a background that looks like it could be smoking related. And it's one thing is, I think, worth emphasizing here is when the patient comes in these scenarios to the clinician, often it doesn't come with a label of, is this RBILD or DIP? That's not how the patient presents. It presents with, recurrent pneumonias, hospitalizations, other things are going on, and it's not immediately apparent that ground glass opacities in a patient are smoking related. So I think the biggest thing that pathology does is to confirm that the changes are in fact smoking related and not related to autoimmune disease or LIP or many other things that can happen here. So let's now switch from this to the whole slide imaging. And can you guys just let me know if you can see the whole slide images here?
You can see them.
You can see it? Okay, great. So I'm going to start actually with the middle lobe. So this is whole slide images from the right middle lobe. And one thing I'd like to show you is right from the lower mag that this is not diffuse disease in the middle lobe. Do you guys agree? Everybody in agreement? Not diffuse?
Yeah, definitely.
And I want to show you, and this it kind of brings up the issue of DIP, DIP RBILD. Would anybody think that this picture is a good fit for DIP?
No.
No.
No, anyone? No.
No.
Right. First of all, there's barely any macrophages, in DIP, at least the classic DIP described, you want lots of alveolar macrophage filling all over the lung. You can quibble about should it be 80%, 90%, 100%, but most of it should be filled, right? There's barely anything here. There are macrophages. Actually, if you go high mag, there are smokers macrophages, a few.
Yeah.
But it's not like how it's described in DIP, right? Irene, would you agree with that?
There are more at right side next to the bronchiole.
Correct. So now let me show you what is actually abnormal here. So here is the abnormality. And I'm going to high mag just to show. So you can see even within this field, there is little bit of normal lung on the right below and very abnormal lung on the left above, which is all expanded. The alveolar septa are expanded. And I hope everybody can agree that there is there's fibrosis in the alveolar septa. Would you agree?
Yeah.
Fibrosis in the alveolar septa, it's ropey, there's interstitial expansion, and there are macrophages. So there are those macrophages. If you go to really high mag, you can see that some of them are pigmented, although it's very faint, the kind of smokers type of pigmentation. It's not very prominent. And then let's talk about emphysema for a second. So guys,
Sanjay,
I want your thought on whether this is emphysema or not.
It might be useful for the audience to go over what you mean by ropey collagen, because I think that's an important.
Yes,
and in this case, nicely shows that.
Yeah, let's change the field and go to another spot and then go to ropey collagen. So let's go here. I just want to show as much of this biopsy as possible, so you get an feeling for the distribution here. Okay, let's go to high mag. And I'm going to almost the highest possible mag here. And what ropey collagen is this stuff in the interstitium or the alveolar septa is collagen, right? It is fibrosis. It's very paucicellular, meaning that there are only a few inflammatory cells. Actually, it's not completely paucicellular. There are some lymphocytes. So there are a few here. There's a few here too, but most of it's predominantly paucicellular. And where the arrow is now is actually the ropey collagen. So it's collagen that actually waves a little like that. You know, it goes, and let me just follow it. It goes like this, up and down, up and down, up and down, up and down. That's the ropey collagen. It kind of has a serpiginous outline. And in SRIF, one characteristic thing is that when you go to some areas, you can actually see smooth muscle bundles intermixed with that ropey collagen. So it goes collagen, smooth muscle, collagen, smooth muscle. It's a very interesting pattern. And you'll see that here and there. Like here, these are smooth muscle bundles. That's not collagen. This is smooth muscle, but it's intermixed with the collagen. So it's a very interesting mix of the two things. But very unlike NSIP, it's not a uniform admixture of, you know, in chronic inflammation and fibrosis. It's the fibrosis that dominates the picture. And unlike NSIP in this, at least in this field, you have a lot of normal lungs. So here, nobody would argue that this is NSIP, right? I mean, you have got completely normal lung in between. And I hope we will agree that although there is subpleural fibrosis here, this is not UIP. Would everybody agree with that?
Yeah.
Why is it not UIP? There's not significant scarring here. There's no honeycombing. There are no fibroblast foci. So I think one of the things worth mentioning here is people actually see this kind of subpleural fibrosis and because we keep on saying UIP is subpleural, UIP is subpleural, the moment they say subpleural fibrosis, they think this can be UIP. And that's not correct. Actually, one of the series cases in our series, it's mentioned in the paper, was actually misdiagnosed as UIP. At an outside institution and came to us with a clinical diagnosis of IPF because of the pathologic misdiagnosis of UIP. So I think UIP is really in the differential of SRIF because of this, because the fibrosis can be patchy, it can be subpleural. And, you know, you think of, you know, another dogma in UIP, this says there should be very little inflammation. There should be very little inflammation. So that's also true of SRIF. You know, there is very little inflammation. So when people look at subpleural, very little inflammation, patchy, I can see why they think UIP in this, although there really is not enough scarring and architectural distortion here to call it UIP.
Actually, I think UIP has more inflammation than SRIF in the scar parenchyma.
Absolutely, absolutely. I totally agree with you,
Makes
Irene.
me think.
Yes, UIP. So what she said is UIP, actually, most cases of UIP have more inflammation than you see in SRIF. Actually, there's more inflammation in UIP than in SRIF. And sometimes UIP can have very florid inflammation because of superimposed OP or DAD or whatever other superimposed things are going on. And before I just go away from the middle lobe, I started with the middle lobe because this has a beautiful respiratory bronchiole. I hope you guys agree. So there's an artery here and a respiratory bronchiole there. You can see it's incomplete. The reason it's a respiratory bronchiole is because there's partly bronchiolar epithelium and partly it goes into the alveolated lung. So the reason I wanted to show respiratory bronchiole is because people ask, why is this not respiratory bronchiolitis? Why is this not RBILD? So let me ask you guys, does anybody here think that this is a respiratory bronchiolitis here within this respiratory bronchiole? Anybody? This is as normal a respiratory bronchiole as you can do. You can put this in a textbook, you know, as a normal respiratory bronchiole. So it would be completely wrong, you know, to label this as RBILD. It does not meet any criteria. If you want to label something as RBILD without any respiratory bronchiolitis, you're free to do that. But that's not the case here. There's nothing, it's not even in the respiratory bronchiole. So that's what I would like to show in the right middle lobe. So now, Matt, I'm
Can I
going
ask
to
you a question about that before we
go
go
ahead,
on?
please.
So as I noticed in the history, she stopped smoking 3 months prior. Is that where like the pigmented macrophages first leave the respiratory bronchiole? Like, because you would expect to see in an active smoker like pigmented macrophages in the respiratory bronchiole, right? And in this case, it seems to be more that they're kind of just left out in the periphery. But I don't know if I've ever correlated that. I don't know.
I'm not sure that a 3-month quitting would immediately result in, you know, going away. But yes, you know, if this person had quit, let's say 5 years prior to this presentation, I'd say now I can understand why the macrophages are gone, because this patient has quit for such a while that most of that thing has gone away. With recent quitting, I'm not sure that I would buy. And as you will see in the other lobes, it's actually not gone away completely. In fact, let me just, you bring up a good point, Matt. Let me just go back.
I think that I don't see it plausible biologically, because we have seen, or it has been reported, that the smoking macrophages are there for 20 years. So
Yes.
I don't think that the macrophages live 20 years. These are new macrophages, baby macrophages that are full of dirtiness that is there. So I don't think that in 3 months the dirtiness has disappeared. So the place of the macrophages, I don't see it plausible.
I guess I was just wondering, do they leave the respiratory bronchiole first? Is that the first place they're lost, right?
Yeah.
But I think the dirtiness would be in the respiratory bronchiole. It's not that the macrophages are there for so many years or for months. If you say they live in 3 months, I think it's not enough. It's not enough to have cleaned the bronchiole. But maybe it's.
Yes, actually, Matt, the data that Irene is citing is in Dr. Katzenstein's old paper, on respiratory bronchiolitis. Yeah. This is the Frege and Katzenstein paper, American Journal of Search Path. And there they showed, and actually they took a very detailed smoking history prospectively in that study. And in that case, they showed that in some cases, like the extreme of that was up to 30-something years, the patient had quit and still there were those dirty macrophages in the alveoli. So I think going away with recent quitting is not very plausible. And I'm not sure. I think the respiratory bronchiole question is a good one. Does it disappear from there first? But I don't know if we have any data. We're just guessing there, what goes away first and how quickly it goes away. We just don't know. So now
I can extrapolate the guessing a little more, because the macrophages are already recruited, right? Like Irene was saying, baby macrophages, the younger macrophages. So the 3 months quitting there, the macrophages are still waiting for the person to go back to smoking so that they can have more exposure to pigment, so that they have more work. So the 3 months is not enough for them to make a decision to decrease in numbers, because they've already recruited so many. So I think that's my story of guessing.
I like it, Raghav. I like that you're giving the macrophages like a mind, they're making a decision, making a decision on whether to eat it. Can I ask you guys a question? I want everybody to chime in, including Sharada, please. So I'm showing you low mag, guys. Do you think there is emphysema here in this section?
I think so.
Yeah, there is.
Like here, I'm going to put the arrow there in the subpleural lung. Would you buy that that's emphysematous?
Yes.
Yeah, so I found in this paper, very interesting thing is that there are cases like this where there is emphysema. It's not rip-roaring like with big bullae or anything, but there is some emphysema. It's not very striking, but it's there on the pathology. And in some of the cases in this series, the radiologist didn't see any emphysema on CT. Even when we went back and reviewed with an expert.
Do you inflate the biopsies?
No, we don't. We don't. Are you?
So
could it be that that's the reason? Is that what you're suggesting?
I sometimes have thought, because sometimes, especially when I tell the residents not to inflate with the straps, because some people have done that, to inflate little pieces of lung, and I think it can clean what is in the alveoli, and it makes it look more inflated.
Yes.
But
yes.
Then when sometimes I have the biopsy and I think, I ask, was this inflated? And nobody can answer that. And
yes, that's a good point, Irene. I think people forget this, that they say, well, inflate it so that the emphysema becomes more apparent, right? Inflate the lung so it becomes, but the problem is when you inflate, the normal lung also gets inflated. So overinflation becomes a problem. So, so you're creating another problem when you inflate, is that you are creating artifactual overinflation. So the emphysema will become more apparent, but the lung will also become more inflated. I think there's kind of a trade-off there. There's no easy answer for whether inflation is good or not. But I think for most of our surgical lung biopsies, we don't inflate in-house. Matt, you were going to say something?
I was just saying, I think in this case, we also have some free-floating like alveolar walls and septa around, which I think is
let me zoom into that. Where was it here? Here, right?
Yeah, it's exactly, because which is hard to get just from overinflation, right? And that's, I don't know what others think, but when I see that, I'm pretty confident that there's been destruction of the walls and not just overinflated.
Wow, good eye, Matt. You spotted those floating things from low mag. Okay, very nice. Best. Okay, should we go silent while I switch to the
I
Sounds
have
good.
a
to the other
question
one?
here.
Okay,
So,
go ahead.
Sharda, you were saying?
yeah, I'm saying like I have a question here. Can the radiologist think of cyst in such in this emphysematous case, in such emphysema? Can they report it as cyst? Like, is it possible?
Well, in this case, Sharda, the one I showed you, they did actually report the one cyst as a cyst. But in the upper lobe, there is actually, you can see it on the images we showed on the paper. You can actually see this emphysema, centrilobular emphysema. You can see it in the upper lobe section. It's just a mild, not very striking with big bullae and stuff like that. But yeah, they do report cysts sometimes, especially if it's discrete. Yeah,
no,
sorry, go ahead.
This emphysema, can the radiology report it as cysts with this sort of emphysematous changes?
If they can confuse emphysema with cysts.
I think it can be, yes. It can be confused. So, I'm not sure. I think we would need a radiologist to chime in, but I think there is substantial overlap between cysts of other causes and solitary cysts in emphysema. That's harder to tell. But the more diffuse the finding gets, the more easier it is to say that is true emphysema. When you see a finding that are diffusely centrilobular, that's unlikely to be any other cystic change and more likely to be emphysema. I find that another thing that radiologists find difficult is when there is thickening in the wall of the cysts. That's when some confusion comes in. Is that SRIF? Is that CPFE? Is that emphysema with cyst with some other ILD going on? So I think the intersection of emphysema and fibrosis causes lots of confusion. And I think that's where it's important to have SRIF as to understand what SRIF is, how it is different from CPFE and UIP and so forth. Not sure if I answered your question, Sharda, but that's my take on cyst versus emphysema in radiology. All right, can I switch, guys? Are you okay with that?
Yeah, sure.
Okay, I'm going to go silent while I do that. Middle lobe biopsy, in that there is a lot of lung that is not fibrotic, like here. There's definitely not DIP or RBILD, at least to my eye, doesn't fit with that distribution. That should be either one. And actually, there is quite clear patchy fibrosis of that kind that you see in SRIF. So again, I want to show distribution. And I find SRIF, it's actually hard to describe the distribution. It's clearly patchy here, but it's not clearly centrilobular or subpleural. It's sort of both, there is subpleural here. Do you guys agree? There's some subpleural fibrosis here, but this fibrosis is away from the pleura. Some fibrosis is centrilobular, like here it's next to the bronchovascular bundle.
Yeah.
This fibrosis, I don't know, it's kind of random. I think if you take that interlobular septum and this interlobular septum, then this is the centrilobular area. And you can make a case that this fibrosis is centrilobular. And I hope everybody agrees this is classic SRIF on the path. Matt, do you have any comments on that? Like, would you call this area RBILD or DIP?
Well, I would not know. I guess the one thing is some of it is a more centrilobular, and I guess you can get a little bit challenged if you find a granuloma or something like that, right? Yes. But I think the fibrosis is still also wrong for a fibrotic HP as well, right? And,
yes, that's a great point. And I think fibrotic HP is also in the differential here because of the thing you mentioned. You might get a little inflammation. What if the patient has a bird? Smoker, it's not like smokers can't have birds. And I've seen that before. I've seen SRIF in a patient who was in a farmer, where they were thinking, oh, could this be farmer's lung? And the patient was also a smoker and had classic SRIF like this. So I think fibrotic HP can be in the differential here, depending on the clinical situation and other findings like that. Any other questions, guys, about the lower lobe finding?
And also wanted to re-emphasize that area, like you mentioned before, ropes and smooth muscle hyperplasia is like alternating between each other. That's very nicely demonstrated in this area. And again, I see, like in this kind of cases, when I see a granuloma or a giant cell, I always feel that this road signs where when you're driving in the highway, you see the road signs, but don't get diverted when you see those road signs. Still go don't change your destination. But do consider in the back of your mind the differential diagnosis. But this is beautiful smooth muscle hyperplasia intermixed with ropes everywhere.
Yeah, Raghav, you bring up a good point. Actually, one thing I wanted to mention is that these cases of SRIF, part of the diagnostic criteria we used here for these cases in this study was they should have nothing else. So they should have no Langerhans cell histiocytosis, no UIP, no significant scarring. We excluded those cases. Anything that was suspicious for UIP, we got rid of that. Suspicious for UIP, no fibroblast foci, no diffuse alveolar damage. But you know that those things can happen in patients who smoke. So you know there are many overlap cases where you have both things, and that's going to be another paper, a different paper altogether.
Mhm.
So these are pure SRIF cases.
So
Yeah, what's that, Sharda?
I was thinking of a burnt out LCH in this as a
Yes, that's actually a great point. So, you know, if there were more stellate scars everywhere and less of this alveolar sept, I would actually seriously consider that. Sharda, I think that's one of the closest things to SRIF is burnt out LCH. But in that, you tend to have more, you know, the scars are more stellate. There's less of this alveolar septal expansion and more of the, so there is, in other words, there is more architectural distortion in burnt out LCH than is in SRIF. But in fact, that's very close. And in burnt out LCH, you can also have SRIF in the background. So it makes it very, very challenging. That's a great point. Great point. All right. So I'm going to.
Both are due to smoking. I was thinking the same as Sharada, that
Yes.
I think airway-centered fibrosis, for me, airway-centered fibrosis has to come with more inflammation and with bronchial metaplasia. This, for me, is classic SRIF, no matter where it is, because we know it can be airways around airway or next to pleura. But scarred Langerhans cell histiocytosis is something I would think.
Yes, that's a great point. Sharda, just and both to you and Irene both, see there's an interlobular septum going here.
Yeah.
So the difference between scarred LCH and SRIF. So here you see this is kind of like a diffuse alveolar septal expansion. This would not be scarred LCH. You know, scarred LCH would be a localized scar. That's the point I'm trying to make. Okay, I'm going to shift now, and now I saved the best one for the last is right upper lobe. So I'm going to switch. Okay, I'm going to go silent and switch to upper lobe. Now we are back to the right upper lobe of this patient. And the reason I think this is just a spectacular example is I think this is the closest that SRIF gets to mimicking fibrosing NSIP. And actually, if you go to now, I want to give a shout out to the 6 patterns thing of Kevin Leslie and Max and the people from Mayo Scottsdale. There's a beautiful description on the 6patterns.org website of how SRIF is a perfect mimic of fibrosing NSIP, and kudos to them for recognizing that, because I'm so happy that somebody else agrees that is, you know, those things can be very, very similar. So I want to show you here SRIF in the upper lobe of this patient looking exactly like fibrosing NSIP. So look at this, how diffuse and uniform the findings are.
Wow.
Look at that. It's just beautiful because it is truly, you know, actually this is more classic NSIP than any NSIP I've ever seen. It's just very uniform. And as you go to the high mag, you see that actually it's the characteristic of the fibrosis that tells you this is not NSIP, that this is SRIF. You can see, just like Raghav pointed out, the mixture with smooth muscle bundles, you see that? The ropey, wavy collagen there, the paucicellular nature. But actually, this is also a case, the right upper lobe, where you could be most likely to call it DIP, because there are actually a lot of macrophages all over. So Matt, here I'm with you, that a case like this, many people would call DIP. So if you ignored the middle and lower lobe and only looked at the upper lobe, you could say, well, why is this not DIP? There are so many macrophages all over the place. And I think what people do in many papers is, instead of showing the overall picture, like I did here, lower lobe, middle lobe, upper lobe, they just show one high mag 40X like this. And they say, this case was DIP, open and shut case.
So can I ask a question then? So what if all the lobes look like this, and there was this amount of macrophages everywhere, what would you call it?
I would still call it SRIF based on the fibrosis map.
Would you comment at all about the macrophages, or
Yes,
does that?
yes,
Okay.
yes. Although
And
I
so,
don't think it makes any difference whether the macrophages are less or more, but I do put that in my comment.
okay.
But I don't, as long as the fibrosis is present, Matt, I always call it SRIF.
Okay.
As long as it's this kind of fibrosis, I always call it SRIF, regardless of how many macrophages are in the back. But I will acknowledge that this is the kind of picture that causes difficulty. You know, this is where you can make the best case that this could be DIP. But nobody could look at the middle lobe and lower lobe and say that that is DIP. And actually, that is an argument against calling it DIP, is that you have big areas of normal lung. It does not fit the criteria. Even if you think that DIP is a good name to give it, it doesn't fit the criteria in this case because of the middle and lower lobe. And the third point I want to make before I go silent and let you guys talk is that it's very important to emphasize that the distribution of changes is actually quite different from lobe to lobe and from slide to slide and from field to field in smoking related entities. It is not as straightforward as is made out in the RBILD DIP paradigm. So RBILD is only around the bronchioles, rest is normal. DIP is everywhere and is quite diffuse. And you can see from this case, I've shown you more detail than you will ever get in any paper, that the changes are actually not that easy to classify. It's patchy, every lobe is different, every field is different, and you can actually get a different diagnosis depending on which field you go to in the same lobe. For example, I can go to, in this particular slide, I can go here, and here the fibrosis is less. It's not that clear-cut SRIF here, but you just go little bit to the side and it's classic SRIF here. So I want to emphasize that as my final point, the variability from area to area in smoking related interstitial fibrosis. Guys, comments before we close this, and this is all I want to say about
So
it.
the differential diagnosis which I have under LOPAR is amyloid in this.
Great point. Great point. And it would not be wrong to do a Congo red just to exclude that. Yeah.
Yeah. The other point I wanted to make was means the figure 2 is brilliant. Like you mentioned, it gives you a global picture of what's going on radiology, the different lobes, how much of ground glass opacities were seen, and the distribution, and then the histopathology, how it was distributed. The point I wanted to emphasize was these were all like some flavor of ground glass opacity, but they were interstitial fibrosis with this characteristic lopical collagen.
Yes.
So because when we are looking at biopsies, or when we are looking at lung, and when we are trying to correlate with radiology, when we see ground glass opacity, we don't jump and think of fibrosis, because you're expecting reticulations, you're expecting traction bronchiectasis, you're expecting some kind of honeycomb changes, but none of that you're expecting. When they say ground glass opacity, you're expecting more of like infection, that kind of setting. So that's, I think, one of the biggest point you also drive in the paper, that you can still expect fibrosis with a specific with a character, and with the baggage comes all the old names and what different people used to call this differently.
Yes.
Like if I use in the comment, like you made a very good point that you would acknowledge that this would be a challenging one, and different people would use some of the previous names. And again, that's where some of the times I also think about it. Should I mention the previous name? And now this is what we think of the new name, something like a new name, or it was already there, like an old wine in a new bottle. So something like that. But I think the important point is it can look like UIP where the subpleural component, but look for other features of UIP and drive away from not going that direction and sticking to what this patient might really have it. Even though there's ground glass opacity and no features of other like radiology features.
Can I make a question to you, Raghav? These are great points. Actually, the point about you don't expect to see interstitial fibrosis when you have ground glass opacity is a great point. Can I ask you a question in return?
Yes,
because I've been thinking about this a lot, because this is a very, very big point that the reviewers brought up and everything. So let me ask you a question. In hypersensitivity pneumonitis, right? Classic cellular HP, where you have ground glass opacities, they are a major feature of the radiology, right? What is it that explains the ground glass opacities?
Yeah, good question. I have not thought about it that way, but I was kind of when you said hypersensitivity pneumonitis, I was going that direction. Um, I feel again, yeah, I feel it's all the inflammation around the airway and the
Where is it?
peribronchial.
Where is the inflammation? In the interstitium, right?
In the interstitium, exactly. In the
Right. So in
interstitium,
ground
because
glass, so in hypersensitivity, we accept that
yes,
interstitial changes can cause ground glass opacities,
correct.
right? But in the smoking related entities, we said, no, 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 it can't be interstitial. It's the
Yeah,
airspace stuff that explains the ground glass opacities. It's actually so interesting to me
yeah,
that in interstitial lung disease, we see an interstitial finding and we say, no, it can't be interstitial. Don't call it interstitial because it's the macrophages that matter. It's such an
correct.
interesting mind game that we have been forced to play, that in interstitial lung disease, we find an interstitial finding, and we have been trained over the decades to ignore the interstitium and only look at the airspace, because we say ground glass can only happen from airspace macrophages. And hypersensitivity, I think, is the classic counterpoint to that. We know that in hypersensitivity pneumonitis, the interstitial findings cause ground glass opacities.
Right.
It's diffuse interstitial lymphocytosis. Even the bronchial inflammatory infiltrate in the bronchioles is interstitial. It's not airspace. So I think this concept should change, is that the macrophages are the only thing. I can accept that the macrophages are contributing to the ground glass opacity. I think that there's no question that, but I think that the interstitium also contributes to the ground glass opacities, and it's not possible to be sure whether it's interstitial or airspace or both. It's impossible to be sure. Same in hypersensitivity. It's impossible to be sure whether it's just the interstitial inflammation or the foamy macrophages that are in the airspaces or both. It's impossible to be sure what is causing the ground glass opacities. Great point, Raghav. You gave me a chance to talk about it.
Just like ground glass nodules. Ground glass nodules are ground glass and are lipidic.
Yes, how about
adenocarcinomas, which are
adenocarcinoma in situ? If I told you, hey, adenocarcinoma in situ, where are the macrophages in the airspaces? How come this is ground glass? Nobody would say, oh, no, no, interstitial things can't cause ground glass opacities. That's the classic example. Thank you, Irene. Another beautiful example of a purely interstitial thing, right? That lines
Can
the
I
alveolar septa that causes ground glass opacity. Great.
can I add one more, since
Yeah.
you said adenocarcinoma in situ and brought up the lipidic? I was also wondering about this as a lipidic type of fibrosis.
Yeah, yeah, because it's purely alveolar septum.
if there is one, this is the lipidic fibrosis.
This is true lipidic.
That just confuse everyone if we call this lipidic fibrosis.
Okay, any comments, Sharda, and last comments before we get off this topic?
Yeah, that's one.
All right.
Can I ask one more question,
yes.
Sanjay, before we go on? It's just I'm interested in what your clinicians think about this, like the clinical respirologists who are getting these reports, and the fact that you call SRIF just in the background lung of a cancer specimen, and also SRIF that's causing this patient's presumed interstitial lung disease. And
Very
how
good
do
question.
they interpret that, and does that create any confusion that we're using this term for two very different spectrums of disease?
So that is a great question, Matt, and you can imagine why this thing has taken. So I joined clinic in 2013, right? Why has it taken 10 years to publish this? So there are several reasons. One is, when I first came here, the clinicians here were not familiar with SRIF, like happens with any new entity, right? It was only 3 years old. So it has taken many, many years on multiple ILD meetings to talk like this, like we are talking now, to explain to them what it means. Similarly, actually, the opposite happened with our surgeons. When they first saw SRIF in our lobectomy cases, again, we've been doing that for the last 10 years, SRIF, SRIF, SRIF. Most of them didn't even care because they knew there was nothing there. There's nothing there on the CT. There's nothing to worry about. Once in a while, one would come and say, hey, what's this SRIF stuff? I say, then so I had a chance to explain to them, hey, sometimes in emphysema, there's some fibrosis, don't worry about it. There was never any problem, and never has any surgeon ever come to me and said, why are you saying SRIF? Now we'll have to give them pirfenidone, we'll have to show them to the ILD group. Nothing ever happened. So that was the surgeon group. Now in the ILD group, it took a lot more discussion, right? Because they are used to the RB-ILD DIP thing. So Matt, you have a great point there. That clinicians, when you first show them this, they think, well, what is this? Why is it different? So I had to go back and forth with them and educate them repeatedly about why this is not DIP, why it doesn't fit with RBILD. And when it does fit with DIP, like in this upper lobe picture, why SRIF is a better name than DIP, why giving steroids to this is not a good idea. And finally, I think the thing that made them come around is when we looked at these SRIF cases, our clinicians looked at this and we had multiple rounds of additional multidisciplinary discussion. Dr. Vehar, who was a fellow is now at the University of Miami, the first author of this paper, went over and over at the history. And when they went back and looked at the patients who did get steroids, in this case, nothing happened to them. So they never improved. There was never any long-term improvement. So they came around to this idea that the idea that something is DIP, we'll give them steroids and those things will get cured is completely incorrect. That's one thing. And the second is that you get a smoking related label with this. They're beginning to increasingly accept the idea that a smoking related label is good for these patients who they are calling smoking related ILD anyway, right? Even without my label of SRIF, they are calling it smoking related ILD. So if I had not even called this SRIF, it had called this DIP, our clinical team would have called this smoking related ILD. So now, Matt, the bottom line is over this last 10-year period, our team, our ILD team is becoming more and more confident with a final diagnosis of SRIF. So the final clinical diagnosis they give is SRIF to the patient. And that's taken a while. You know, it doesn't just happen. We can't just say, oh, the ATRS ERS said this is SRIF, so we call it SRIF. You know, it's taken more of a iterative step-by-step approach. But your question is completely valid. And I know why people hesitate to do this. It would have been much easier that some guru consensus committee on the top would have said, now call it SRIF instead of DIP. That would have been much easier, right? Everybody's life would have been easier. But in new entities, that never happens. You know, somebody has to push the envelope. And that somebody is us.
Yeah. Well, the consensus committee of the Fresh Air Group calls this SRIF. So
if you guys support me, that'll be another big thing, you know, because we are a nucleus of pulmonary pathologists. You know, we can change the discussion on this topic if we are united on that. You know, it's
Yes.
possible.
So
I second, third, fourth, that.
In my reports.
What's that, Sharda?
I have started using the terminology of SRIF in my report. Means the specimens are not for SRIF, of course, they are for emphysema or bulla. That was the specimen which I got. And then I use the term because I saw these findings, all the typical collagenized fibrosis, and also I have used it in my impression.
Yes, I think, you know, as people use it more, clinicians will get used to the idea of seeing it in a report. Then they will talk to you about it. You can explain it to them. You know, it takes time, but it builds up. And I'll tell you one more final thing before I stop. That SRIF is now on Wikipedia. Just Google it and see. There's a Wikipedia entry for SRIF.
Wow, that's amazing. That's great.
All right. Thank you guys for humoring me. I really, really appreciate it for the chance.